Welcome, everyone, to the 11th CITF seminar series event, People at Higher Risk Due to Health Conditions, Other Health Conditions, and COVID-19. My name is Dr. Kate Hankins, and I will be your moderator today. I'm the co-chair of the COVID-19 Immunity Task Force, and I'm also a professor and interim chair of the Department of Global and Public Health at McGill's School of Population and Global Health. Before we get started, I've been asked to share some instructions as we are providing simultaneous translation into French, and we'll have a bilingual question and answer period. I just want to point out that a couple of our presenters have pre-recorded their talks, but their question and answers will be considered in the question and answer period. So, bienvenue à tous et à toutes au 11e événement de la série de séminaires du groupe de travail sur l'immunité face à la COVID-19.
11th
Mon nom est
session
Dr.
of the
aujourd'hui.
CITF,
Avant
and
de
I will
commencer,
be
on
your
m'a demandé
moderator
de
today,
partager
Dr. Kate
quelques
Hankins. Before
instructions
I
car
start, I
après
was
nous
asked
offrons
to
une
share
traduction
a few
simultanée en
instructions
français
as we
et
offer
nous aurons
simultaneous
une période de
interpretation
questions
into
et
French,
réponses bilingues,
and we will have a bilingual question period, including for the two speakers who are
At the bottom of your
pre-recorded.
Zoom screen, you will see an icon of a
Au bas
globe.
de votre
Choose
écran Zoom, vous verrez
if you're
l'icône.
bilingual and you want to hear only the live feed. English attendees, you should select the English option so that you can hear the entire event in English. The presentation will be in English, but the question and answer period will be bilingual. Au bas de votre écran Zoom, vous verrez l'icône d'un globe. Choisissez off
At
si
the
vous êtes
bottom of
bilingue
your
et
Zoom
que vous
screens,
souhaitez
you will see an icon of a globe. Choose off if you are bilingual and want to only hear the live feed.
afin de
English
pouvoir
attendees, you should
l'événement en
select
français.
the French
La
option so
présentation
you can
sera en
hear the
anglais,
entire
mais
event
la
in
période de
French. The
questions et
presentation will
réponses
be
sera
in English, but
bilingue.
the question and answer
Veuillez
period will be
sélectionner votre
bilingual.
langue préférée
Please
maintenant.
choose
Please
your
go ahead,
selected language now.
select your language preference now. So let me tell you a little bit about the COVID-19 Immunity Task Force. We were established in April 2020, seems like a long time ago, by the Government of Canada with the mandate to catalyze, support, fund, and harmonize knowledge on SARS-CoV-2 immunity for decision makers across the country, but in particular for federal, provincial, and territorial decision makers to inform their efforts to protect Canadians and minimize the impact of the COVID-19 pandemic. Next slide, please. We have over 119 studies, and we're going to focus today, as you can see, they're spread right across the country, but we're going to focus today on 9 of them, which are about people at higher risk of severe COVID-19 due to other health conditions. Next slide, please. We have a number of presenters. We'll begin with Dr. Deepali Kumar, who's a professor of medicine at the University of Toronto and a transplant infectious diseases consultant in the University Health Network. She's director of transplant infectious diseases in that network. Then we'll hear from Dr. Vinod Chandran, who's an associate professor at the University of Toronto and the staff rheumatologist at the University Health Network and Sinai Health. Then we'll hear from Gil Kaplan, who is a Killiam laureate and professor of medicine in the Division of Gastroenterology and Hepatology at the Cummings School of Medicine at the University of Calgary, which happens to be my alma mater. And then Dr. Sarah Wing, who is a clinical associate in the Division of Nephrology at St. Michael's Hospital in Toronto. Next slide, please. Then we'll hear from Anne Birchall, who's a scientist at the MAP Center. I don't know what MAP is, so maybe she'll explain to us, for Urban Health Solutions at St. Michael's Hospital, Unity Health Toronto, an associate professor in the Department of Family and Community Medicine at the University of Toronto. And then we'll hear from Cecilia Kostyniuk, who is associate professor, faculty of medicine and health sciences at McGill University in the Department of Medicine, the Division of Infectious Diseases at the McGill University Health Center, where she is a scientist. And joining us for the Q&A, we will have Dr. Sasha Bernatsky, who is a professor of medicine at McGill University and a senior clinical research investigator at the McGill University Health Center Research Institute, and Matthew Oliver, who's an associate professor, University of Toronto, staff nephrologist, and the division head of nephrology at Sunnybrook Health Sciences Centre, and regional medical lead for the Ontario Renal Network, Ontario Health. Next slide, please. So let's begin first with land acknowledgements. Our speakers today, and I'm speaking on behalf of McGill first, our speakers today are living and working in various places across the area of Turtle Island, now known as Canada. It just so happens most of us are either speaking from the city now known as Montreal or the city now known as Toronto. Dr. Kaplan is the only one speaking from Alberta, so he will offer his land acknowledgement during his presentation. So I'll lead us off and will acknowledge the land that I'm on at McGill on behalf of myself, Dr. Klesteniuk, and Dr. Bernatsky. We are speaking to you from our place of work at McGill University, which is on land that has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabeg nations. And we acknowledge the colonial origins of Montreal and McGill University and the many ways in which we perpetuate this history in our present day. We encourage everyone to engage in decolonizing efforts beyond just land acknowledgement. We thank the diverse Indigenous peoples whose presence will always mark this territory on which we gather together today. I would now like to ask our first speaker from Toronto, Dr. Deepali Kumar, to acknowledge the land she and her co-presenters are on.
Thank you very much, Kate. So I would like to acknowledge, do this land acknowledgement on behalf of Dr. Chandran, Wing, Burchell, and Oliver. And we are all presenting from Toronto, and we appreciate the opportunity to present from Toronto, which is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples. And this is now home to many diverse First Nations, Inuit, and Métis peoples, and we are thankful to be able to present from here.
Thank you, Dr. Kumar. So today's topic is about people at higher risk of severe COVID-19 due to pre-existing health conditions and or the immunosuppressant drugs they are on. And the reality is that these health conditions affect nearly 10 million Canadians. I was really struck by this slide. I actually didn't know that there were 40,000 people living with a transplant in Canada. And I had no idea 7 million Canadians have immune-mediated inflammatory diseases. Chronic kidney disease is not uncommon, with somewhere between 1.3 and 2.9 million Canadians affected. I did know that 62,000 people are estimated to be living with HIV in Canada. And when we look at the right-hand side of this slide, we can look at the impact of COVID-19 for these populations, either in terms of a higher hospitalization rate, as I've seen with transplant recipients, or, for example, the immune-mediated inflammatory diseases. This is quite striking, 8.27 versus 4.88 COVID-19 related deaths per 1,000 person years. That's almost double. Hospital admissions also much higher for people with these conditions. Then if you look at the chronic kidney disease, I was really struck by this, that a mortality rate of 45% in COVID for people who have a chronic kidney disease versus 5% if they didn't have COVID-19. The same kind of thing we're seeing with higher rates of hospitalization. And then for people living with HIV, a 78% higher risk of death when compared to people without HIV. These are really striking. So we're going to learn more about these during the seminar today. And if we can move to the next slide, There, I'll hand over to you, Dr. Dipali Kumar, to tell us a bit about people with solid organ transplants. What is their risk? What have you seen in your study?
Thank you so much. Before I start, I would like to acknowledge that I have received clinical trials grants from Roche and GSK, and I also have received honoraria from some industry partners, and I will be discussing off-label use of vaccines. So with regards to solid organ transplantation, this is a group that includes all the different organs that you can think of to transplant. So this includes kidney transplant recipients, liver, lung, heart, pancreas, and combinations of organ transplants as well. And as was mentioned before, there are over 40,000 people living with a functioning solid organ transplant. And every year in Canada, there are around 3,000 of these procedures performed. So you can see that every year this population is growing. And the important thing to note is that transplant recipients are on lifelong immunosuppression in order to prevent rejection of the organ. And so the immunosuppression is continues for the duration of life for these recipients. Now, what is the rationale for further study of COVID-19 vaccine in immunocompromised, especially transplant? We know that 2 doses is truly not enough. And we know from previous work that many patients with a transplant develop no antibody or T-cell responses after 2 doses. Patients have more breakthrough infections with severe disease, and this was known before Omicron. So those that had received 2 doses of vaccine were having lots of breakthrough, and this breakthrough was just as severe as if they had not been vaccinated. And it was certainly more than the general population. We also know that variants can evolve in the immunocompromised state. So patients tend to shed virus for longer, and this means that you can have mutations in the virus and evolution of the virus. We also know from other vaccines, like the flu shot, that immunocompromised patients need higher doses of vaccine or additional doses to have the same immune response or a better immune response than what we give as a standard of care. And you know, when it was recommended that immunocompromised get 2 doses, and when it was seen that there were a lot of breakthrough infections happening, there was huge patient demand. And we could see that in the emails we received, social media, etc. So this led to us doing a randomized trial in the transplant group of a 3rd dose of COVID vaccine. And what you see on your right is how we assign patients to either the 3rd dose of Moderna vaccine or a 3rd dose of placebo. This was done at a time where only 2 doses were recommended, so we were able to do this trial. The doses were given at 0, 1, and 3 months. So the 3rd dose was a couple of months after the 2nd dose. And patients were blinded, so they did not actually know what they were getting. And the outcome was essentially immunogenicity. So it was antibody response and T-cell responses. Next slide. So here are the results from that study. Basically, we found that the 3rd dose vaccine increases antibody and T-cell responses in transplant recipients. And I'll take you through some of the data on this slide. The first panel actually shows the antibody response, and the red are the patients that received the actual vaccine, the 3rd dose. The blue are the patients that received placebo. And what you can see is that about 55% of patients who received the 3rd dose vaccine met the cutoff for antibody response, whereas only 18% met the cutoff for the placebo. The second panel shows you how people increased. And you can see that some patients these are the red dots, some patients who received the third dose who had not responded at all to the second dose really had a great response with the third dose. The third panel goes through neutralization, and the fourth panel goes through the T cell response, which you can see was also higher with the third dose. Next slide. So interestingly, 1 day after this study was published, the FDA in the United States came out with a recommendation to give this third dose vaccine for all immunocompromised individuals. And in fact, we had been dealing with the FDA for a couple of months prior to this recommendation and sharing our data with them even prior to publication. And it was really nice to see our study being discussed on CNN by some prominent CNN newscasters. Next. And so we could not rest for too long because, in fact, Omicron was right around the corner. So just to say that the previous study that we did was done using ancestral virus, and all the data was relevant to the ancestral original strain. But with Omicron, we had more to deal with. Next slide. So what we found was that 1 month, as well as 3 months after the third dose of vaccine, there was in fact reduced neutralization against the BA.1 strain of Omicron. And just to take you through this data, on the y-axis, you see the neutralization, so which is expressed in log ID50. The higher, the better, of course. And at the bottom, you see how well the third dose neutralized BA.1 for wild type Delta and then Omicron BA.1. And so what you can see is that the third dose produced neutralization in about 50 to 60% of patients for the original virus, which we knew. About the same for Delta, which was good. But then for Omicron, this dropped significantly to between 15 and 18%. And what we saw was there was, in fact, a 200-fold reduction in neutralizing activity against Omicron, even with 3 doses. Next slide. So that was all done in the laboratory, but how does this really translate into clinical protection? And I think this is where it's important to know that just because something is shown in the laboratory doesn't mean that the vaccine is not necessarily working. So this was a study that we did in the solid organ transplant cohort, which showed that 3 doses is in fact very good in terms of preventing severe disease. So even if people do get Omicron infections, they are protected against severe disease. And so what you can see in the table is that in those that had received more than 3 doses of vaccines, so that was 190 patients, there was only 8% that required oxygen. Whereas if they had received less than 3 doses, and this was 103 patients, 26% required oxygen. So definitely having more doses of vaccine significantly reduced the oxygen requirement at day 30. It also significantly reduced the need for hospitalization. And in fact, even if people were hospitalized, having more than 3 doses of vaccine reduced the number of days that they were in the hospital. So all was not lost just because we didn't have a lot of neutralization. Next slide. But we do know that immunity wanes, and it is important to get booster doses. So what you see here is an ongoing study, and what I'm showing you in this graph on the y-axis is your antibody levels, and on the x-axis is the number of doses. This is a study across Canada of over 500 organ transplant recipients. And so what you can see is as the number of doses increases, so does the antibody response. And in fact, the 4th dose increases the antibody response even further. Interestingly, though, those that actually had COVID infection, so these are patients that broke through after 3 doses or 4 doses, have an even higher antibody response. And that's what we call hybrid immunity. Next slide. Interestingly, when we look at the solid organ transplant group, there are many different types of transplants, as I had mentioned, and the different types of transplants respond differently to vaccines. So you can see that the lung transplant recipients have the lowest antibody responses, probably because they really are the most immunosuppressed of all the different organ groups. Whereas the liver transplant recipients have pretty good vaccine responses. 3rd and 4th doses, almost every liver transplant recipient responds. So you can see that there's heterogeneity even within the solid organ transplant group. Next slide. And then, one thing I wanted to mention, I talked a bit about hybrid immunity, which is immunity you get if you have been vaccinated and then infected. What we have learned is that even in the transplant population, the immunosuppressed population, that hybrid immunity actually does offer some cross protection, at least for a little while. So in this slide, what you see are patients that have been infected with BA1, and you can see that almost 90% have developed neutralizing antibody after being infected. Of course, this population was also vaccinated. When we look at this group and we see how many have developed cross protection to BA5, we found that 69% actually also developed some protective antibodies to BA5. At least in the short term, it appears that there is some cross protection to be had if a transplant patient develops Omicron infection. Of course, we don't want them to develop infection because of all the complications and the long-term issues. Next slide. So the take-home messages then are that 3 doses of mRNA vaccine should be considered the primary series in transplant recipients. Having at least 3 doses prevents severe COVID-19. Booster doses are, of course, very important since protection does wane over time. And it's really important to ensure vaccination of the circle of care, caregivers, friends, and family as well. And with that, I will thank you and acknowledge our research group, as well as the number of collaborators, the UHN Foundation, who supported a lot of our study, and of course, CITF, who has supported one of the largest studies that we've done. Thank you.
Thank you very much, Dr. Kumar. That was fascinating. Both the immediate knowledge translation you got with your trial, which was translated into an FDA decision within, it seems like almost hours, if not days. And then secondly, looking to see, it's great to see the response that transplant recipients have to the vaccine, even in the midst of this tsunami that we had that was Omicron. So we'll come back to you in the question period. Thank you so much. We're going to hear now from Dr. Vinod Chandran, who had to record his presentation. And I just remind you that we will be able to take questions at the end regarding this presentation. Dr. Chandran.
Thank you, Dr. Hankins, for the kind introduction. I'll be speaking on immunity to SARS-CoV-2 mRNA vaccines in patients with immune-mediated inflammatory diseases, so-called IMIDs. I wish to acknowledge that I sit on the following advisory boards: AbbVie, Amgen, BMS, Eli Lilly, Janssen, Novartis, Pfizer, and UCB. I receive salary support from the Pfizer Chair Rheumatology Research Award at the University of Toronto, and I also acknowledge that my spouse is employed by AstraZeneca. For the IMPACT study, we aim to recruit 150 participants that were adults with inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, psoriatic disease, as well as healthy subjects with or without maintenance immunosuppressive therapies who have been vaccinated with Pfizer-BioNTech and or Moderna SARS-CoV-2 vaccines. We excluded patients who had prior COVID-19 infection, were on steroids, as well as who received other vaccines. We ultimately recruited 26 healthy controls, 9 patients not requiring immunomodulatory therapy for their IMID, 44 patients on anti-TNF agents, 16 on anti-TNF with azathioprine or methotrexate, 10 on anti-IL-23s, 28 on anti-IL-12/23, 9 on anti-IL-17, and 8 on azathioprine or methotrexate. Our group had 80 patients with inflammatory bowel disease, 18 with psoriasis, 22 with psoriatic arthritis, 12 with ankylosing spondylitis, and 4 with rheumatoid arthritis. We observed that for the entire cohort, the antibody responses, as measured by automated ELISA, increased from time point 1 to 2 and 3, and then decreased by time point 4. After the first dose, 97.6% of the participants, as well as 80% of participants, seroconverted for the spike and RBD respectively, and the relative ratios were greater than the medians of the convalescents in 44.6 and 13% of the participants. The seroconversion rates increased to 100% for spike and 99.2% for IBD soon after the second dose. And the spike and anti-RBD levels were greater than the median levels of convalescent patients in 96.1% and 85.3% of the participants, respectively. However, participants on anti-TNF and anti-TNF with methotrexate or azathioprine therapies had significant lower levels of anti-RBD and spike antibodies than those in the healthy control, IMID untreated, and IL-12/23 groups after the first and second doses of the vaccine. Moreover, the anti-TNF and anti-TNF with methotrexate azathioprine therapy groups had greater decline in anti-RBD and anti-spike IgG levels compared with the healthy controls, untreated IMIDs, and IL-23 groups. So if you look at time point 4, the group of patients who show lower levels over here, the patients who had waning responses were primarily in the anti-TNF treated groups. We then used spike serotype lentivirus assay for the detection of neutralizing antibodies and demonstrated that in IMID patients had weaker neutralization responses in to mRNA vaccines at all time points and for all the variants of concern tested then. Particularly patients on anti-TNF agents with or without methotrexate or azathioprine, as well as those on just methotrexate or azathioprine, had no detectable neutralization against the Omicron variant of concern. Looking at T-cell responses, we determined that by measuring the release of cytokines in cell culture supernatants following stimulation with peptide, that the deficient T-cell responses, particularly interferon gamma, after dose 1 was corrected at dose 2. However, by 3 months post-dose 2, T-cell responses, specifically interferon gamma and interleukin-2, were lower in most treatment groups as well as in untreated people with IMIDs relative to controls. When we analyze antibody responses by vaccine type at time point 3, we showed that those who received 2 doses of the Moderna vaccine elicited a higher humoral response, the stronger humoral response than the Pfizer vaccines. And among those patients who received the Pfizer vaccine, males had a slightly lower response to RBD compared to females, whereas antibody responses did not differ by age in this particular study. So to summarize this part of the study, data based on antibody response showed 100% seroconversion with increased antibody responses from type 1 to time 3. Antibody levels and neutralization efficacy were lower in those on anti-TNF treatments than in controls. and responses wane substantially by 3 months after days 2, and especially in those people with IMIDs, and therefore need more boosting. Based on T-cell responses, we showed that all patient groups showed T-cell responses after first dose of mRNA vaccine, with some improvement after second dose, but IL-2 and IL-4 responses waned within 3 months after the second dose compared to the healthy controls. IL-2 and IL-4 responses were more pronounced after the second dose. We saw stronger responses to 2 doses of Moderna versus 2 doses of Pfizer, and although I did not show it today, there was positive correlation between T-cell responses and antibody responses. However, the small number of subjects in each study group and the heterogeneity of drugs and disease within each group are obvious limitations to the study. We then evaluated antibody responses after third doses of mRNA vaccine. As you can see here, anti-spike and antibody levels, anti-RBD antibody levels increased following the third dose, with 92% of patients showing relative ratios greater than the medians of the convalescent for spike and RBD. You'll recall that we showed significant waning of IL-2 and IL-4 responses by 3 months post-2 in the T-cell responses. Here we show that when we look at pooled responses, the third dose of vaccine corrects this waning immunity, significantly boosting both IL-2 and IL-4 responses. We additionally assessed T-cell responses against Omicron B.1.1.529, but observed no differences in IL-2 and IL-4 responses compared to the wild type, similar to other studies. So to conclude, we observed robust serological and cellular responses in people with IMIDs following third dose of SARS-CoV-2 mRNA vaccine. The third dose restores the waned T-cell immunity and antibody-mediated immunity in patients with IMIDs by 3 months after the second dose, and people with IMIDs retain T-cell immunity to Omicron B.1.1.529. And we are now conducting additional cellular and humoral readouts, looking at durability of responses and the effect of additional doses in this cohort. With that, I'd like to acknowledge other members of our study, particularly Professors Ingras, Watts, Silverberg, and Igwe, as well as all the study participants and the staff who made this study possible. I'd also like to acknowledge our multiple funding sources, especially the CITF. Thank you, and I'll hand it over back to Dr. Hankins.
Thank you, Dr. Chandran. It's fascinating, and you wonder about the impact of the drugs, which drugs are more likely to cause a delayed response. But good to see that that third dose does make a difference, as we saw in our first presentation. Our next speaker also had to pre-record. It's a real challenge getting all these busy people together on one day. I'd like to introduce Dr. Gilad Kaplan, and Dr. Kaplan, please take it away.
Thank you, Dr. Hankins. Hi, everyone. Sorry I couldn't be there in person. I'm excited to share data with you on antibody response following the first, second, third, and fourth dose of a COVID-19 vaccine in those with inflammatory bowel disease. This is a study conducted in Calgary and is part of the Canada-wide Succeed project. I'd like to take this opportunity to acknowledge the traditional territories of the people of the Seven Treaty region in southern Alberta, which includes the Blackfoot Confederacy, comprising of the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. Please review this slide for my potential conflicts and disclosures. My research team at the University of Calgary led a cohort study to evaluate the decay of antibodies over time and to explore whether a third and fourth dose mRNA vaccine recovered falling antibody levels over time. Each dot on this figure represents a person with IBD who provided a blood sample to measure their antibody levels after the first, second, third, and fourth dose of a vaccine for SARS-CoV-2. After first dose of a COVID-19 vaccine, only 82% of people with IBD seroconverted with an average antibody level or a geometric mean titer of 280. However, within 1 to 8 weeks of receiving the second vaccine dose, 99% seroconverted with an average antibody level of over 4,000. After 8 weeks from the second dose of the vaccine, antibody titers fell by approximately 15% per week, down to an average antibody level of 1,100. Antibody levels measured within 1 to 8 weeks following the third vaccine dose result in a robust recovery of antibody levels. The geometric mean titers exceed 12,000. Similar to a second dose, antibody levels decay by approximately 12% per week after 8 weeks, with the average antibody levels dropping down to 4,200. A fourth dose subsequently recovers antibody levels. Average antibody levels are over 10,000. These data demonstrate that sequential vaccine booster shots recover antibody levels in IBD patients. But are there factors that are associated with a lower response following a booster shot? This is a 3D plot of antibody levels across 3 axes: antibody levels, time from third dose of the vaccine, and age groups. These circles represent antibody levels for those over the age of 80 years. Among those aged 70 to 79, antibody levels are on average higher, which can be seen as each group becomes younger by a decade. Overall, antibody levels are higher in younger IBD patients over time from third dose. These data suggest that older patients with IBD would benefit the most from a fourth dose of the vaccine. What about the effect of different classes of drugs after 3 doses of the vaccine schedule? This figure shows antibody levels across the first dose, 1 to 8 weeks after the second dose, and 8+ weeks after second dose, stratified by the major classes of IBD medications. Across all therapies, we see a rise in antibody levels following the second dose that falls after a few months. However, you can see that a third dose of the vaccine recovers the depressed antibody response across all medication classes, with the exception of prednisone, where antibody levels remain flat across each dose of the vaccine. These data show patients with IBD who are actively flaring and require treatment with prednisone at the time of administering a vaccine mount a significantly lower antibody response afterwards. Now, I want to pivot towards the safety of the COVID-19 vaccines. I want to highlight novel data from 2 large studies. The first is a US cohort from Cedars-Sinai that explored adverse events after each of 3-dose regimen of a COVID-19 vaccine in those with IBD as compared to the general population. The second is a study that I led from the University of Calgary, where we interviewed patients about their self-reported adverse events following each of 4 doses of the vaccine. When you evaluate both the US and the Canadian data, we learned that side effects immediately after each vaccine dose are most commonly injection site pain, fatigue, and malaise. Less than 12% report gastrointestinal symptoms following vaccination. Symptoms post-vaccination are similar in frequency, severity, and duration to the general population. Adverse events in those with IBD are mild and become less frequent with each dose. In fact, our study found that those with IBD who reported an injection site reaction after their 4th dose had 3-fold higher antibody levels compared to those who didn't experience pain after their shot. Thus, a strong reaction to the vaccine likely reflects a strong immunological response to the vaccine. In our Calgary study, we interviewed everyone for active GI symptoms within 30 days of the vaccine dose and confirmed via medical chart review whether anyone had an objective evidence of flaring their disease. Reassuringly, no one experienced a flare of their disease activity within 30 days of any of the 4 doses of the vaccine. I want to reflect on the importance of Canadian data in supporting the IBD community during the pandemic. On March 11, 2020, when the WHO announced COVID-19 was a global pandemic, Eric Benchamal, who is a pediatric gastroenterologist from SickKids, and I created Crohn's and Colitis Canada's COVID-19 and IBD task force. we invited a nationally representative group of experts, including adult and pediatric gastroenterologists, scientists, infectious disease specialists, nurses, and patient representatives. Data generated from cohorts like our IBD study in Calgary and the Succeed cohort were used to create guidelines for the IBD community, healthcare providers, and policymakers. I want to close by highlighting some key messages for the IBD community. Across 4 doses of the COVID-19 vaccine, antibody levels rise and fall and recover in those with IBD. Older individuals with IBD may need booster shots as they mount a lower antibody response to vaccines. COVID-19 vaccination safely produces a robust antibody response across all IBD drug classes, with the exception of those flaring on prednisone. Adverse events in IBD is similar to that of the general population. The risk of flaring post-vaccination is exceedingly low. I want to thank the members of my lab who worked tirelessly during the pandemic to conduct our IBD serology study on COVID-19 vaccines. Finally, I want to thank my partners and funding agencies. Thank you very much for your attention. For those who will have questions on our results in people with IBD, Dr. Sasha Bernansky is with you live to answer them. Please also feel free to email me if you have any questions. Dr. Hankins, back to you.
Thank you very much. One question that's coming up for me, and we'll get to it in the Q&A period, is what about the timing of booster doses in the populations that we're looking at? We're looking at the impact, but I'm just wondering if it would be different from the general population. So thank you very much, Dr. Kaplan. I'd now like to introduce Dr. Wing. So on behalf of Dr. Matthew Oliver and Michelle Hladanovich, Dr. Wing will present the team's research regarding people on dialysis. Dr. Wing.
Thank you. It's a pleasure to be with you today. So I'll be speaking today about a study looking at the effectiveness of 3 doses of COVID-19 vaccination among individuals on dialysis during the Omicron period in Ontario, Canada. Next slide, please. I have no conflicts of interest to declare related to this study. So individuals on dialysis are at a higher risk of COVID-19 for many reasons. One being as they suffer from other chronic conditions. Severe infection and death rates were quite high during earlier waves of the pandemic. Previous studies did find that two doses of COVID-19 vaccine were effective in reducing COVID infection in the dialysis population. However, this was when Alpha and Delta variants were predominant. Dialysis patients in Ontario were prioritized for a 3rd dose in December of 2021. This was just as the Omicron wave was beginning. So our questions for this study were related to vaccine effectiveness or clinical outcomes. The first question being, was a 3rd dose effective in reducing infection during Omicron in the hemodialysis population? The second question was a 3rd dose effective in reducing severe outcomes, namely severe infection requiring hospitalization or death during Omicron? And does prior infection play a role in reducing the risk of future infection? Next slide, please. So this was a retrospective cohort study, or a study looking back from December 1st, 2021 to February 28th, 2022. And this looked at 2 versus 3 doses of an mRNA vaccine, either Pfizer or Moderna, in dialysis centers across Ontario. Vaccine status was defined at the end of the study. So we had a total of 8,457 participants or individuals on hemodialysis. And it's important to note that at the study start, 28% of individuals had received a 3rd dose, whereas at study completion on February 28, 2022, 88% of patients had received a 3rd dose. In the group who received 3 doses, 86% received all the same type, so all Pfizer or all Moderna. And of note, 627 individuals had a prior infection, and individuals with a prior infection were less likely to receive a third dose. Next slide, please. So what did the results reveal? So they revealed that there were lower rates of Omicron infection in the 3 versus 2 dose group, and there were lower rates of severe outcome. This was translated into vaccine effectiveness, and namely there was a 42% reduction in infection in the 3 versus 2 dose group, and a 60% reduction in severe outcomes. As a reminder, severe outcomes includes hospitalization and death. Next slide, please. A secondary analysis also was completed to look at the role of prior infection. So we calculated hazard ratios, which assessed the risk of infection during Omicron, taking into account prior infection versus no prior infection, and the number of vaccine doses, 2 versus 3. The lowest hazard ratio or risk was seen in individuals with prior infection and a third dose. This was translated into a percentage as seen on the slide. Of note, although there were higher point estimates for Moderna in comparison to Pfizer, there was no significant difference by vaccine type. So in conclusion, it is important for hemodialysis patients to be informed of the benefits of vaccination and any mRNA vaccination. Our hope is that vaccination continues to be prioritized for hemodialysis patients, as they are a high-risk group and there was clear benefit with 3 versus 2 doses. Prior infection is likely protective, but this study also highlights that the lowest risk was with prior infection and a third dose. So vaccination does provide additional protection. Further studies are needed in terms of the impact of COVID-19 on long-term morbidity and mortality in the dialysis population, and also, as alluded to, waning of vaccine effectiveness in the dialysis population and timing of boosters. Next slide. I'd like to extend a thanks to our study team who worked very hard during the study and analysis. It was a pleasure being here.
Thank you, Dr. Wing. It's interesting because it's a message that we need to get across to the general population as well. It's not one done and dusted. If you've had Omicron infection, getting a booster at the appropriate interval is important to maintain your protection. So thank you for that. We'll come back to that, I'm sure, in the question period. So I'd like to invite our next presenters, Dr. Cecilia Kostyniuk and Anne Birchall, to present on behalf of the research team led by Dr. Aslam Anas. Dr. Birchall, I believe you are starting off.
Thank you, Dr. Hankins. It's a pleasure to be speaking with you today with my co-presenter, Dr. Kostyniuk, on behalf of a large national team where we'll be speaking about vaccination among people living with HIV. Neither Dr. Kostyniuk or myself have conflicts of interest to declare for this presentation. I would like to provide a bit more background about why it's important to look at COVID vaccination among people living with HIV. Historically, there has been a common finding that they have poor immunogenicity to vaccines such as the flu vaccine, pneumococcal vaccine, and hepatitis A and B vaccines. And that's especially true for people with low CD4 cell count or who have detectable HIV viral load. People living with HIV are also affected by a number of other risk factors that increase the risk of COVID-19 and severe outcomes, and that includes many people living with HIV are also living with other comorbidities, and many are adversely affected by social determinants of health, such as low incomes. While people with living with HIV were included in some of the clinical trials for vaccination, those who were generally didn't represent the broader spectrum of people living with HIV, and so we wanted to conduct this research that we're looking at from a number of angles. So in the next slide, we'll get started with findings where we're looking at vaccine effectiveness against infection with SARS-CoV-2 and against COVID disease among people living with HIV. So I'm going to be sharing findings from 2 ongoing projects in Ontario and British Columbia, where we're using a test negative designed to estimate vaccine effectiveness using linked administrative health data, where we're able to work with data from virtually all adults living with HIV in the 2 provinces. For our work, we restricted to people who had had a test for SARS-CoV-2, a PCR test specifically, and these findings are restricted to the pre-Omicron period. We are actively working on estimating vaccine effectiveness since that time. And the way we're able to look at vaccine effectiveness and estimate it is by comparing vaccine status between those who test positive for SARS-CoV-2 versus negative. So in our next slide, you'll see the first batch of results from these findings. Again, this is pre-Omicron. Here is vaccine effectiveness against infection with SARS-CoV-2. The broad messages from this slide are that 1 dose was better than 2 back in the pre-Omicron period, not surprisingly, but that there was evidence of waning of protection against infection starting around 4 months. Not shown here in the slide, but the BC group led by Hasina Samji was able to also compare their vaccine effectiveness estimates to a matched negative HIV negative sample and found that pattern of waning against infection outcomes was a bit quicker among people living with HIV than people who were not. Then in the next slide in Ontario, we were able to look at outcomes beyond infection and found that 2 doses gave substantial protection against symptomatic infection with vaccine effectiveness of 94% and against hospitalization or death with vaccine effectiveness of 97%. We didn't see evidence of waning protection against symptomatic infection up to 6 months, but we weren't able to look at it for hospitalization or death due to insufficient power and precision. We were able to look at, did this vaccine effectiveness vary according to certain characteristics, and found no evidence of it varying by age, men versus women, where people lived in Ontario, the number of comorbidities they had, or the pandemic wave, at least up until that period before Omicron. So before Dr. Kosteniuk begins to speak about the immunogenicity findings in this project, I'll just quickly mention some of the conclusions we're drawing so far in the next slide. So in this pre-Omicron period, 2-dose vaccine effectiveness was broadly similar among people living with HIV compared to the general population. And given that most of the people in these 2 provinces are generally well controlled with their HIV, that may provide some reassurance for people living with HIV and their healthcare providers. But we have more work to do. As I said, we're continuing to look at this protection against Omicron variants. We're very interested in looking at 3rd doses and time since last dose going beyond that. We didn't have information on AIDS-defining illness, CD4, or viral load suppression, but suspect that would be important, and we'll be following that up in Ontario. We do recommend, as others have underlined, definitely for people living with HIV, important to get their booster doses and be up to date. Now I'll ask Dr. Kosteniuk to continue.
Great, thank you very much. So now I'm going to present to you on AIM-2. What is the immune response to COVID-19 vaccines among people living with HIV? And as Dr. Burchill alluded to, a major reason we were interested in conducting this study was to look at participants who were excluded from the initial early studies involving people with HIV on COVID vaccine immunogenicity. So this was a prospective study involving people receiving vaccinations in Montreal, Toronto, Vancouver, and Ottawa, and who were followed at HIV clinics in these cities. And our control group consisted of HIV uninfected individuals in the Stop the Spread Ottawa cohort. And here you can see the participants we included in this analysis. So we had 294 people with HIV and 267 controls. Of the people living with HIV, the median CD4 count was 650. About 7% had a CD4 count under 250. 7% had a CD4 count between 250 to 349. About 10% had actually had a detectable viral load at one point in the previous 6 months. And there was 8 people who were what we call immune non-responders, or people who do not mount a good CD4 count despite having a suppressed viral load on antiretrovirals. And about 30% of our population had multimorbidity. Next slide, please. So as you can see from these violin plots, the third dose of COVID vaccine elicited a stronger immune response, irrespective of whether you had HIV or you did not have HIV. And we measure, or we defined a COVID-19 vaccine immune response as co-positivity to IgG receptor binding domain and spike protein. We also then looked to see what happened to the responses between at different time points. And you can see that at the 6-month post-dose 2 time points, there was a slightly smaller number of people with HIV who mounted a positive vaccine response. But by the third dose, this difference disappeared, and 100% of our participants mounted a vaccine response by the time they received their third dose. We also looked to see if there was any differences in our population based on the sex, and we did not find any differences between males and females in the percentage of people mounting a vaccine response. And we were also very interested to look at subpopulations of people with HIV, because people with HIV are a very heterogeneous population. They vary greatly in terms of age, number of comorbidities, and their immune status. So we were especially interested by looking at people who were what we call unstable, or people we defined as having a CD4 count of 350 or less, 2 or more comorbidities, or being over the age of 55, because these are populations which tend to have worse outcomes in general. And what was very interesting was that we actually did not see any differences in the vaccine response between the people with HIV who were greater than 55, had low CD4 counts, or who had multimorbidity. And then we also did a comparison to see if there was any differences in the percentages of people mounting detectable antibody responses based on whether they received an mRNA versus a non-mRNA vaccine. Although we did have quite a smaller number of people receiving non-mRNA vaccines, nonetheless, we did not note any significant differences between groups, which was reassuring, because it showed that regardless of the type of vaccine, there was still a very good vaccine response. And we also looked at time interval between the first and second COVID vaccine doses. And once again, we did not see any differences between antibody levels following the third COVID vaccine dose, depending on these time intervals. So to conclude, we found that adults with HIV, with well-controlled HIV on antiretrovirals, mount an antibody response similar to HIV-negative individuals following the second and third COVID vaccine doses. Fewer people with HIV had detectable antibodies following the second dose, so timely boosters are required, and this difference disappeared by the time the third doses were received. We do need, however, more information on durability of antibody responses, neutralization capacity, and the contribution of cell-mediated immunity to COVID-19 vaccination. And taken together, all these findings will help to inform clinical practice guidelines for people living with HIV. And we'd, of course, like to thank our very large study team and all the participants in this study, as well as the members of the community advisory boards for COVAX HIV and the CHEST study. And of course, we're very thankful to all of our funders, including the CITF, the CTN, and CIHR and ISIS. Thank you.
Thank you, Dr. Birchall and Kosteniuk. This is a lot of information. It was encouraging again to see good responses to the vaccines. I want to thank everybody for their interesting presentations and move to the next slide. We'll do a couple of slides that are the key takeaways from what we've heard, and then we'll move to the questions and answers. And I know I've been checking and it's been a very busy question and answer session going on with people answering things in the chat. So we'll see if there are new questions coming up, and you can always expand on any of the questions that you've already begun to answer in the chat. So our key takeaways so far: COVID-19 vaccines have proven to be safe for people at higher risk of severe COVID-19 due to pre-existing health conditions. The vaccines have worked really well in generating immune responses and in warding off severe disease and death in various high-risk populations. It's interesting, in most cases, 3 doses, not 2, should be considered the primary regimen. And actually, you know, there's debate for the general population and for everyone, should this have been seen as a 3-dose primary regimen in the first place? Next slide, please. So keeping up to date with the recommended vaccine booster schedule with a dose every 4 to 6 months is important to sustain adequate levels of protection. And perhaps in the discussion period, we can talk about what is the best interval for which populations. The new bivalent vaccines may offer greater protection, but it's too early to say for sure. So I'd like to know whether any of the studies are going to be able to look at that. And people with other health conditions that are similar to the ones we've discussed today, they may be at more risk of severe COVID-19, and they should continue to be cautious. And I read this, you know, wear masks, physical distancing, avoiding crowded settings, and getting regular boosters is what we're saying to everybody right now with this trifecta that we're experiencing with COVID and the flu season taking off, in addition to respiratory syncytial virus. So let's move now, if we can, to the question period. I know many of you in the audience may have questions you felt a bit shy putting in the Q&A. Stay in the language option that you prefer and enter your questions if you haven't already done so. And we'll do our best to answer as many as we can in the time remaining. I'd like to welcome Dr. Sasha Bernatsky to the Q&A session. She's leading the task force funded work on people with immune-mediated inflammatory diseases. And I'd also like to welcome Dr. Matthew Oliver, who is the co-principal investigator on the task force funded work investigating people with chronic kidney diseases. Thank you both for joining us. Now, if I look in the Q&A, I can see there have been questions that have been being answered about specific mortality, for example, in people with chronic kidney diseases. I don't know if you want to comment on that at all. It was a suggestion that the mortality was a bit high. That was something you answered, Dr. Oliver. Do you want to just comment on that?
Yeah, I'm happy to. Thank you very much for inviting me to this session. There's a wide spectrum of chronic kidney disease. It goes all the way from mild decreases in kidney function all the way to kidney failure requiring transplantation or dialysis. Our talk was focused on chronic dialysis. In that population, in the early part of the pandemic, the mortality rate was about 20 to 25%. If the patients acquired COVID-19, and the hospitalization rate was 60%. So it was very high in that population. It wasn't quite at the 47% rate mortality that was quoted at the beginning, but still very, very high. Also, patients with advanced kidney disease not on dialysis also have similar rates. And then a lot of the patients with kidney disease are also receiving immunosuppressive medication. So it really varies depending on the population. Those rates have thankfully come down over time as with the different waves, and have come down with the receipt of vaccination. But at the beginning of the pandemic, it was very high rates of mortality and hospitalization.
Okay, thank you. We have some open questions coming in. There's one, so for immunocompromised, IBD and anti-TNF, thinking about the 5th vaccine dose, and maybe this is something we can think about for all of the populations. How long do you recommend that people wait to get the booster after having COVID infection? A lot of people got Omicron in that Omicron tsunami. So how long do you recommend waiting? And is there a particular booster, bivalent Moderna, the B1, the Pfizer BA.4/5 that you would recommend? So let's start looking at the first of all, the immunocompromised patients with IBD, and then we can look at maybe the other populations.
Do you want me to answer?
Yeah.
Okay.
That'd be good.
So I would tend to follow whatever the local guidelines are in terms of like for Health Canada or for the province in terms of offering the vaccination after the infection, but in general, like at least by 3 months, because this wasn't highlighted in the presentations, but it seems like an infection has a bit of the same effect in these IBD and other similar groups of boosting, but it's still possible. The waning happens as well. So within 2-3 months, people should probably be getting another booster after an infection.
Okay, and would people say that about other populations? Is that about the interval you're thinking too? I'm seeing heads shaking yes. Okay, let's look a little bit at hybrid immunity. So Dr. Kumar, you implied that for hybrid immunity, the sequence is important, the vaccination and then infection. Did we understand that correctly? And do the dosing intervals matter?
So, I didn't mean to imply that the sequence is important other than we had looked at that particular sequence. I think that, hybrid immunity means you have had infection and you have had vaccination. Now, which one came first? I don't think that that's the issue when we try to define hybrid immunity. So definitely it does seem that in our population, the solid organ transplants, as well as other populations, hybrid immunity does seem to be very, very protective, at least for some period of time. And I think that period of time needs to be defined. In one of the studies that our group has done, and I didn't present this data, but we have seen neutralizing antibodies at least out to 3 months after having infection. And this is in people who had vaccine first. So they had vaccine, they got infected, at least up to 3 months, they seem to be quite protected. What happens after that, I think, is unclear. So I think, for the previous question where you asked when should patients get a dose of vaccine, a booster after being infected, I think 3 months sounds like a reasonable option. But then, I think we need more data on waning immunity. And I think immunity does wane. It's just how long, what is the interval, I think, needs to be looked at.
And I guess the question is, what booster?
So what booster? I mean, so I think some of the trends that we, prior to the bivalent vaccine, some of the data showed that the Moderna mRNA vaccine seemed to provide more antibodies anyways than the Pfizer vaccine. And that might be because Moderna has, a greater number of micrograms of antigen than the Pfizer vaccine, 50 versus 30 micrograms. I think it's important to get for immunocompromised, it's important to get the vaccine that you can get your hands on first. I don't think that I would not split hairs on this. I think one may produce a little bit more antibody than the other, but they're both I would say, equally protective in that sense. So I would say just to get whichever one is available.
Does anyone else want to comment on that question?
I'll just say as well, I agree with what the other speakers have said. I think it's just a matter of, following the latest recommendations and taking whichever vaccine is available. Sometimes in research or in the lab, small differences are detected, but we don't often know the clinical meaning of this. And at least for our study with HIV, we saw that even non-mRNA vaccines induced a good antibody response. So it's important just to take whichever one is available and recommended. And whether these small differences translate to clinically meaningful events later is something, we'll know more with time.
I think
that's a good. Go ahead, Sasha.
I was just going to say, I think all our patients are getting the bivalent now, though. I think that's definitely a shift.
There's a question that's come in that says, okay, so we're tracking the waning of these levels, and we're assuming that means less protection. Are you seeing in any of your populations an increase in the risk of severe disease before that next booster? Do you see the clinical impact start to show of that waning?
I can answer for the dialysis population that we did do a subgroup analysis based looking at waning in terms of reducing the risk of infection and severe outcomes. And there did appear to be some evidence of waning. We broke down the intervals into 3 months, so 3-month intervals after the second dose and 3-month intervals after the third dose. And there was some evidence of waning, although the sample sizes were not large enough to really be precise about it, but there was some evidence of that in the actual infections and severe outcomes, not just the serology levels. I would like to make one quick point that early in the pandemic, we were quite concerned about the antibody levels in dialysis patients, which were shown to be much less than a healthy population. But the vaccine effectiveness, and this is of the first and second dose, was much higher than we expected. So there can be differences between the serology levels being seen and what the actual vaccine effectiveness was in the population. So that was quite reassuring to the dialysis community and our patients.
Thank you. I know that Bruce Mazur at the task force would prefer that we talk about decaying levels and that we don't assume it's waning, that we actually look to see what is the immune protection despite decaying levels of antibodies and so on.
Can I just add? Can I just add that
sure.
It's actually very difficult to look at waning or decaying immunity at this point because we have all these early treatments. So what's happened is that when a immunocompromised person or a person at risk of severe disease gets COVID, we are very quickly administering, for example, nirmatrelvir, ritonavir, or remdesivir, the antivirals that we have. And so that also impacts how severe the disease can get. And so it's very difficult to parse out the effect of the early treatments versus, decaying or waning immunity.
And even prophylaxis, like Evishield is used in our highest risk people.
Absolutely. Yeah.
That's a really good point. So how about in patients with inflammatory bowel disease? Is that also the beginning
So
I
think,
go ahead.
I think the picture is also very similar in immune-mediated autoimmune diseases, that we haven't seen a big spike in hospitalizations or severe COVID, but it's with the same caveats that were mentioned.
So in chronic kidney disease, dialysis patients and so on, are they also candidates for Paxlovid or some of these other antiviral agents right away? And you think that, Sarah, do you think that would affect the immune response? Blunt it, perhaps? Or Matthew?
Caveats. One, well, Sarah, you jump in here too. I mean, we did measure the actual acquisition of infection. So the vaccines were preventing the patient getting the infection. Now, in terms of the severity of the infection, it is being influenced by all of these different interventions, and our patients are receiving them. Even Paxlovid was originally felt not to be safe or approved in dialysis populations, but through our work, we were able to show that patients could receive it safely, and it did appear to have a beneficial effect along with remdesivir and other treatments. So kind of a mix. I agree with Dr. Kumar saying those things are reducing severity, but we're also avoiding infection itself, at least in the dialysis population.
Sarah, did you want to make a comment? If not, I'll move to the next question.
Several questions.
You're on mute.
Oh, can you hear me?
Yeah.
Yeah, we have several questions in the chat as well, so I think it's okay to move on.
Okay, so this is a question for all of you, and it's a tricky one. It's, many people with comorbidities are already living with disabilities. Is there any comment on the chances of developing long COVID, whether vaccines are reducing the risk of developing long COVID? What are you seeing in your populations?
That's not something I could comment on.
I think as well for the HIV population, a few people get long COVID, but they're in such small numbers that it's really impossible at this point to make any commentary about it. Perhaps over time, when cohorts from around the world pool their data on long COVID in, the HIV population, we may learn more. But at this time, I don't think I can make any comment.
And I'll just say in the solid organ transplant population, again, it's very similar to what Dr. Kostyniuk mentioned. The numbers are small. We are looking at long-term impact of COVID. And one of the other things we're looking at is the development of cardiac disease and the development of, metabolic disease, diabetes, new onset diabetes after COVID. I think those are some of the longer term issues that also need to be highlighted.
Yeah, I think we're just beginning to get a better feel about, how long COVID is and what its long tail might be, and, how long does it take to resolve, because it does resolve in many people. There is a big national study that's been trying to get an estimate that we'll know more about soon as to how many Canadians are experiencing long COVID. Here's a question that's come in, and it's interesting because it's one that applies to the general population as well. So there's several studies showing there might be a benefit to waiting 6 months or over 6 months between doses, that you get a higher immune response and better vaccine effectiveness. And a recent report from the US on the effectiveness of BA.4/5 bivalent vaccine showing higher relative vaccine effectiveness with an interval of 6 months. So these are large population-based studies, and they may or may not include people with underlying conditions and immune compromise. So is there any evidence to support a shorter interval? You were all, I think, agreeing that 3 months, post-infection, and I assume you meant 3 months since your last vaccine dose as well, for an interval for immunocompromised patients. Is there any thought maybe that it should be longer?
In some of the data in IBD or autoimmune diseases, there's evidence that between the first and the second, delaying at least 6 weeks was better, but I don't know of any evidence suggesting that there should be a delay of 6 months, and that's not what we're doing clinically.
I think Dr. Oliver mentioned this in terms of the dialysis population. However, we recently looked at waning, and although the sample size wasn't large enough to really power, we did see that vaccine effectiveness waned after 3 months. So in the 3 to 6 months group, it had waned in comparison to within 3 months after the 3rd dose. I don't know if you want to add anything, Dr. Oliver, either.
Okay, so we have had several attendees asking about the use of Evishield specifically versus vaccination in these populations. So who wants to comment on that?
So maybe I can start. So yes, so we, Evishield is passive antibody, and it is approved by Health Canada for use in moderate to severe immunocompromised, especially those that don't mount a response to vaccine. And, it is being used across Canada, though there is variability in its use. So some provinces have not recommended it, others have been using it. There's also variability in the dosing of Evishield. So some provinces are using the standard dose, which is 300 milligrams. Some are using the higher dose, 600 milligrams. But I think, whether it, studies have shown that in the at-risk population, it does seem to reduce infections and the severity of infections. In fact, there are smaller studies in the organ transplant population. There's at least 2 or 3 studies now that show that it reduces the number of infections as well as the severity. I think the issue that's arising with Evishield is the changing variants, that are coming now, especially BQ 1.1 and BF7, et cetera, which in vitro, so in the lab, don't look like they are not going to be, where Evishield is not going to be effective against them. And so, the recommendations for Evishield are also changing based on that. And I think, I think that's the issue that's coming up with Evishield. But in studies, it does look like, at least for previous Omicron variants, that it has been effective.
Thanks. Sasha, you have your hand up.
Just
Dr.
that
Bernatsky.
it's not an alternative to vaccination. I think we agree on that. We're asking our patients to get vaccinated. But what Dr. Kumar said is the same for our populations. And I think the use of it is really different across jurisdictions. Even so rituximab exposed autoimmune disease patients tend to be sure that they are receiving Evishield if possible, but there are other patients that might benefit from it, those on mycophenolate or other agents, but those aren't always targeted.
I think as well for the HIV population, again, vaccination is the #1 recommendation, and Evishield would only be used really in certain cases if, the person probably has another reason, such as, they're on rituximab or they also have a renal transplant, some other reason to suspect they don't have or they require that protection. And in general, most of the people with HIV that I've met lately who do get COVID, they get very mild symptoms lately, and it hasn't been causing a large amount of health problems. So again, we haven't really had the need to use Evishield very much in our population, and we encourage just vaccination and booster dosing.
I'll also add that vaccination is very important. It provides some level of T cells, which Evusheld would not, which is, Evusheld is strictly passive antibody. So I think definitely, as my colleagues have said, vaccination would be the first priority.
So there was a question just talking about vaccination that came in asking about how well we're tracking long-term side effects. I guess my first question would be, are these populations experiencing more side effects to vaccines than the general population? And secondly, are you tracking out longer in these cohorts, whether there are other things we hadn't considered in terms of impact from vaccines?
We were quite concerned initially about particularly very autoimmune diseases like systemic lupus. And we haven't seen a lot of, the Bell's palsy or Guillain-Barré or those kind of really rare but important severe reactions. So there's been a handful in the SUCCEED, like a couple, I shouldn't even say handful, in the SUCCEED study. But overall, it seems the symptoms that people may have after vaccination appear to be what they would be in the general population. And we are, at least for the SUCCEED study, we're following people long-term. So we're hoping to get information up to a year on people's booster doses. Now, there is one difficulty studying this issue, is that it could be people who didn't react very well to the first two tend to be the ones who are hesitant to get the third, fourth doses and so on. But with that limitation, we are trying to get a good handle on to reassure people that it's okay to get their boosters. So the safety issues for people who have autoimmune disease are not just those, like I said, Bell's palsy, Guillain-Barré, myocarditis. It's also, would these be causing a disease flare? And our party line in these conditions are that it's better to be vaccinated than to get an infection. If you were to get infected, we think that would probably stimulate the autoimmune process more than getting the vaccination.
I'll just say in the solid organ transplant population, I think the overall side effects, the local and systemic side effects that we've all experienced in the first few days after vaccine, I think those are very similar. But again, as with all these populations, there are some specific things that we need to follow. So for the organ transplant population, we look at organ rejection, for example. Is there any signal that vaccines are affecting the organ itself? And we have not seen any signal on that. So we believe that even for our population, the vaccines are very safe.
And the same applies for people living with HIV. We don't see increased risks of adverse effects compared to the general population. Most of the effects are very transient and mild, and we haven't really seen anything, severe, long-lasting. Sometimes people may be concerned because they may experience what we call a viral blip, or when the viral load just becomes slightly detectable, but that can happen with any cold or flu or infection. So it's really nothing to be concerned about, and it's definitely better to get vaccinated instead of getting the infection.
Thank you. That's encouraging. In fact, this whole seminar has been very, very encouraging, hearing the good responses, I guess, except for people who are on doses of prednisone who are not responding well while they're on the prednisone, but otherwise good responses to vaccine in these different cohorts and patients. So unfortunately, I think it is time for us to begin to wrap up. We've had another round of very interesting results presented by our presenters. And I have to use the time, unfortunately, to give a few announcements. But first of all, I want to thank all of our presenters today, Dr. Deepali Kumar, Vinod Chandran, Gilad Kaplan, Sarah Wing, and virtual, and Cecilia Kostiniuk. And thank you very much to Dr. Sasha Bernatsky and Matthew Oliver for joining us for the Q&A period. Thank you all for your research, your expertise, and your time today. I'd of course like to thank all of our attendees as well, and thank you for sharing your time with us today, and I hope you enjoyed the seminar. The CITF team will be preparing a summary of this seminar and will make it available as usual on the CITF website. And the team will also post a recording of the whole seminar in the coming days. The presentation is already on the website as a PDF in case you want to check back on something, have a look at it, or share it with other people. If you receive the task force weekly newsletter, you'll be informed as to when everything is up on the page. And if you don't receive our newsletter yet and you'd like to, please go to the CITF website's homepage and sign up at the bottom. The CITF's next research results and implications seminar will be in late January. Please stay tuned for more information. Again, you'll find details in the CITF newsletter, on our website, and on our social media pages. Here are the ways to get in touch with us at the task force or to stay abreast of our news. I encourage you to follow us on social media as well. That's all for today. Thank you again for joining us. Take care and goodbye, everyone.